Thanks you for nice presentation. Our topic about how to improve EGSI outcome in tubal factor infertility. At first, we should know the anatomy and physiology of fallopian tube. Fallopian tube is about 10 to 13 centimeter in length and about 0.5 to 1 centimeter in diameter. The channel of the tube is lined with mucous membrane, with a layer of mucous membrane that has many folds and papillae. Tubal fluid has a complex mixture of oviduct secretory proteins. It contains serum transitate, electrolytes, albumin, immunoglobulins, transferrin, and a specific glycoprotein that is released during ovulation, which is the oviductal glycoprotein, which has a role in fertilization. So the function of fallopian tube is gamete and zygote transfer to and from the uterus and fertilization in the ampullary part of the fallopian tube. So tubal pathology account for about 25 to 35% of female factor infertility in the form of either tubal block, either proximal tubal block or distal tubal block, salpingitis, which is maybe part of a PID or isolated salpingitis, and the last is hydrosalpinx, which we face a lot in cases of recurrent failure or recurrent IVF failure. So hydrosalpinx is defined as distally occluded, dilated, fluid-filled fallopian tube. Distally occluded, fluid-filled. It's found in about 10 to 30% of couples with infertility. Hydrosalpinx is a form of tubal damage. So the lining endothelium is damaged, so it can't absorb the fluid secreted inside the fallopian tube. It can be caused by intrinsic or extrinsic inflammation, either ascending salpingitis or from outside by peritonitis or endometriosis or previous pelvic surgeries. So does it have a bad effect on IVF outcome? Yes, of course. Studies found that the success of ART, especially IVF for patients with hydrosalpinx, is reduced by half. Also, there is increase in the percentage of early pregnancy loss and percentage of ectopic pregnancy in cases of hydrosalpinx. So what is the mechanism? The exact mechanism is still unclear, but there is theories it could be related to mechanical effect of hydrosalpinx fluid or toxic effect of fluid on the gamete or zygote, alteration of endometrial receptivity by the fluid of hydrosalpinx. A study showed that hydrosalpinx fluid, if compared with blastocyst culture media, we found that hydrosalpinx fluid has a higher pH and lower level of potassium, calcium, magnesium, and glucose level. So it is deleterious for gamete and zygote. Also, it have an effect on embryogenesis. If embryos cultured in hydrosalpinx fluid, they found that there is reduced development and of embryogenesis, and this effect is increased by increasing the concentration of hydrosalpinx fluid. So hydrosalpinx fluid has effect on embryogenesis, so it affects the development of embryos inside the tube. Also, it has bad effect on the pelvic vascularity. Studies showed that hydrosalpinx is associated with impaired endometrial and ovarian blood flow, which may adversely affect the endometrial receptivity and the oocyte quality. So, when to suspect or which patient does I screen for hydrosalpinx? Patient with a history of PID, endometriosis patient, previous pelvic surgeries, recurrent implantation failure, or you may find hydrosalpinx accidentally during your ultrasound scan for infertile patient. Diagnosis of hydrosalpinx, first hysterosalpingogram is useful for diagnosis communicating hydrosalpinx, not diagnosis of hydrosalpinx. So what is communicating hydrosalpinx? Communicating means that hydrosalpinx communicate with the uterine cavity. So there is no block or no corneal obstruction in this place. So hysterosalpingogram is useful for only diagnosis of communicating hydrosalpinx. But the conclusive or the diagnostic test is 2D ultrasound. You can see this shape. It's characteristic for Hydrosalpinx, which is sausage-shaped, fluid-filled structure near the ovary. You may have septation inside this cystic structure. So the conclusive diagnosis is 2D ultrasound, and then you do hysterosalpingogram to confirm communication between uterine cavity and fallopian tube, and the last you do laparoscopy for confirmation of diagnosis and management. So this is ovary and this is the fallopian tube showing Hydrosalpinx. So you suspect when you do follicular scanning and you find this sausage shaped beside this ovary, so the diagnosis is Hydrosalpinx. So you diagnose Hydrosalpinx and you are preparing a case for IVF. So what is your management? A study was done showing management for Hydrosalpinx in many ICSI centers in Europe. It showed that about 67% of centers doing laparoscopic salpingectomy, about 1.8% doing salpingectomy by laparotomy, not laparoscopy. So it's a very minute percentage. Also about 20% doing salpingostomy, only drainage of the Hydrosalpinx. About 9% only doing proximal tubal occlusion by laparoscopy. About 81% giving antibiotics, and about 18% giving antibiotics with corticosteroids, and about 12% doing ultrasound guided aspiration. So we'll discuss with each point. First, salpingectomy. What is with and what is against? Salpingectomy is useful because it decreases the risk of infection after oocyte retrieval. So by removal the fallopian tube, you avoid entering by your needle inside the fallopian tube. So decrease the risk of PID or infection after ovum pickup. Also decrease the risk of adnexal torsion. If you look to the distended fallopian tube, which is disconnected from the uterine cavity, so it's free from both ends, so it can twist easily, especially with enlarged ovaries. So by removing the tube, you avoid the risk of adnexal torsion. Also increasing the accessibility of the ovary, because huge tube may distort the anatomy, so it make ovum pickup very difficult. Also, it improves the outcome of ICSI after salpingectomy. But on the other hand, what is against? Negative effect on ovarian reserve. So after ovarian stimulation, it may affect the response. It decreases the number of oocytes, decrease the number of embryos, decrease of the cryopreservation or vitrification rate. Also, it could be challenging, especially in cases like this case. You go for bilateral tubal ligation, you found this tube easy, but the left tube is embedded within adhesions, ovarian and colonic and uterine. It's very difficult to do salpingectomy in this case, so you only do tubal disconnection only without doing salpingectomy. So the drawbacks of salpingectomy: difficulty in cases like this, and decreasing ovarian reserve or decreasing the outcome after ICSI. So a lot of studies has done to compare, to show the effect of salpingectomy on the IVF response. Some studies said yes, it decreased AMH and decreased number of oocytes. On the other hand, two studies said no, there is no adverse effect on IVF response. And one of these studies, it was a meta-analysis in 2016. This is a recent meta-analysis in 2019. It showed that the number of retrieved oocytes and total FSH dose between salpingectomy group compared with non-salpingectomy group were similar. So there is no harmful effect of salpingectomy on the outcome of ICSI. Also, live birth rate, clinical pregnancy rate, implantation rate in salpingectomy group were higher than the non-salpingectomy treated group. So this meta-analysis, which is a recent meta-analysis, showed that there is no harmful effect of salpingectomy on the outcome of ICSI. This is a chart showing there is no effect on the number of retrieved oocytes. Also, on dose of FSH, there is no difference between a salpingectomy and non-salpingectomy group. On the other hand, implantation rate was in favor with salpingectomy group. Also, clinical pregnancy rate was in favor of salpingectomy group. So salpingectomy improved live birth rate, clinical pregnancy rate without affection of retrieved number of retrieved oocytes or the total FSH dose needed for this cycle. The other option is laparoscopic proximal tubal occlusion. A meta-analysis showed that the ongoing IVF pregnancy rate of proximal tubal occlusion and salpingectomy were superior to no intervention. So it is comparable to salpingectomy and it was superior to non-intervention. Another study comparing salpingectomy with tubal occlusion only, it was done on 106 patients. It showed similar ongoing pregnancy rate in salpingectomy and proximal tubal occlusion. Also, meta-analysis show a similar clinical pregnancy rate and a similar live birth rate between salpingectomy and proximal tubal occlusion. The recent meta-analysis showed the same result. It is technically less demanding, so it can be used in difficult cases. May be considered a valid alternative to salpingectomy in Hydrosalpinx treatment, especially in one with severe periadnexal adhesion, in order to decrease the morbidity for the patient. The third option is ultrasound-guided aspiration of Hydrosalpinx fluid. Randomized trial done on 160 patients with ultrasound diagnosed Hydrosalpinx aspiration compared with salpingectomy. Ongoing pregnancy rate were similar to salpingectomy, but a sector of these patients has a rapid reaccumulation of Hydrosalpinx fluid, and it affected significantly the pregnancy rate. So ultrasound-guided aspiration may be useful, but it has a higher reaccumulation rate, which may affect, or it affected really the pregnancy rate if compared with salpingectomy. The fourth method is sclerotherapy. After you aspirate the Hydrosalpinx fluid, you measure, it's about 15 millimeters, so you inject absolute alcohol, half the dose. If you aspirate 15 millimeters, so you inject 7 millimeters, wait for 5 to 10 minutes, then aspirate. Give antibiotic, prophylactic antibiotics. This is sclerotherapy. You do damage to the endothelium, so there is no reaccumulation of Hydrosalpinx fluid. Sclerotherapy is considered successful when the fallopian tube contains no fluid or less than 10% of the previous amount of fluid. This is after 2 weeks from the procedure. Efficacy, it has a similar clinical pregnancy rate and comparable miscarriage rate if compared with salpingectomy, but it has a higher level of complications. It leads to abdominal pain. If ethanol leakage into the abdominal cavity, it's very painful. It may lead to ethanol intoxication. Also, pelvic adhesions and infection. Recurrence of Hydrosalpinx occur in about 20%, which is a high percentage. Another method, which is not recommended now for usage for treating Hydrosalpinx, which Essure system. This device has been withdrawn from the market in some European countries and USA and Canada. Also, the use of Essure system before IVF is off-label use because it's only a contraceptive coil inserted inside the fallopian tube, not for treating Hydrosalpinx. A meta-analysis showed that live birth rate, cumulative birth rate after Essure treatment was significantly lower if compared with salpingectomy or other surgery. So Essure isn't effective in treating cases of Hydrosalpinx before IVF. Complication of Essure system, Essure placement associated with pelvic pain, which may necessitate removal of this device. Also, there is complication related to pregnancy, such as dislocation due to dilatation of the fallopian tube. Also, embryotoxicity of the nacal within the system. Also, negative implantation effect due to the coil inserted. So, if you will do laparoscopy for either salpingectomy or proximal tubal occlusion, you should consider low voltage or low power of the electricity or of the bipolar before cutting the tube or before occlusion the tube, because the heat or thermal effect or thermal damage of the bipolar may go to the ovarian vessels and it affect the ovarian reserve. It affects the outcome if you put the electricity for a longer time or with high power. So decrease your voltage, decrease the power of the device in order to spare the ovary. And stick to the mesosalpinx, stick to the fallopian tube. Don't touch the ovary. Outcome after surgery in a Cochrane meta-analysis involving 646 women in a 3 randomized controlled trials showed that higher ongoing pregnancy rate in pre-IVF treatment group compared to no treatment. The benefit seem to be higher with Hydrosalpinx, which is bilateral and visible on ultrasound. So there is improvement after surgical correction of Hydrosalpinx before IVF. So if you do salpingectomy or proximal tubal occlusion, when to start your cycle of ICSI? This study compared 3 groups. Group started in less than 10 weeks, second group within 10 to 16 weeks, and the third group in more than 16 weeks. The higher pregnancy rate, the higher clinical pregnancy rate and the implantation rate was in the second group, which is between 10 to 16 weeks after the surgery. So you should wait from 3 to 4 months after doing salpingectomy or tubal occlusion, because the effect of surgery, because of the effect of diathermy and necrosis of tissues may affect, it may make inflammatory environment which may be hostile for implantation. So wait at least 10 weeks before embryo transfer in IVF cycle. So our conclusions: Hydrosalpinx affect IVF outcome. It decreases IVF outcome about half or 50%. Salpingectomy is the first choice. Plan B, proximal laparoscopic tubal occlusion. Plan C, no hysteroscopy. I invite you to attend every next webinar next week on 4th of September, which is on the controversy in ART practice. Thank you for your attendance. Waiting for your questions. Thank you.
Thank you very much, Professor Mohamed, for the very nice presentation.
Thank you.
I would like to have a couple of questions, or actually a couple of comments. First thing is that you mentioned no hysteroscopic occlusion, because it is present in practice a lot without any evidence. So thanks for this comment, and I would like to know your practice. Did you stop doing this hysteroscopic occlusion, and what are you going to do in cases with frozen pelvis, which is very difficult to reach that tubal end?
In cases of frozen pelvis, I tried to expose the proximal end of the tube close to the uterus, about centimeter. Only do adhesiolysis for about 1 centimeter of the fallopian tube adjacent to the uterus. Then I do bipolar coagulation for this small segment, short segment, and then cut, bipolar undercut. If I can't reach this point, and it is evident by ultrasound, I did sclerotherapy for 2 cases, and one of them was pregnant.
Sclerotherapy with
Last
alcohol?
choice with alcohol. I did it with alcohol and tetracycline. Absolute alcohol 95% and the tetracycline 5%. the last choice and the last resort is hysteroscopic pole coagulation of the corneal end, but it has a high failure rate, high recanalization rate. I do hysteroscopy today and then do embryo transfer after 1.5 months because there is a high recurrence rate after 3 months and recanalization. So it is a last resort if I fail to do anything. If I fail to do salpingectomy or proximal tubal occlusion or sclerotherapy, it's last resort. I do hysteroscopic coagulation of tubal ostia.
Okay. Regarding easy cases, there are no adhesions or minimal adhesions. Your first choice will be salpingectomy or tubal or proximal tubal occlusion.
If it is small hydrosalpinx, I do bipolar coagulation and cut. Small hydrosalpinx, bipolar coagulation and cut. If it's a mega hydrosalpinx, huge hydrosalpinx, it's better to do salpingectomy to avoid abscess formation or PID, to avoid torsion, to avoid distortion or recurrent inflammation which may affect implantation. So huge hydrosalpinx or mega hydrosalpinx, it's better to do salpingectomy, not tubal occlusion. If it is not feasible, if it is very difficult, it's mega hydrosalpinx, but a lot of colonic adhesion, you can do bipolar coagulation and cut or disconnection, and then you make a drainage for this hydrosalpinx. You make a large opening and you coagulate the surface to avoid adhesions. Coagulate outside. If you do this opening, you coagulate outside in order to invert the edges to avoid occlusion. This is a drainage to decrease the size of the hydrosalpinx. But if you can do salpingectomy, it's better.
Dr. Hassan, do you have questions to Mohamed?
Excellent presentation, Mohamed. Thank you very much. In case of communicating hydrosalpinx that is evident by hysterosalpingography and not seen by ultrasonography, do you operate?
No, I first diagnose by ultrasound, because if you have a distal tubal occlusion without hydrosalpinx, if you inject the dye inside the uterus, it will lead to the fallopian tube, it distends the fallopian tube, give false appearance of hydrosalpinx. Hydrosalpinx means accumulation of fluid during the resting phase. So if you do ultrasound without injecting any dye, you see distended fallopian tube. So don't depend on histopharyngogram for diagnosis of hydrosalpinx, only for diagnosis of communication only.
So to confirm your advice to our audience, hysterosalpingography, dilated tubes is not an indication for surgery.
Yes.
The indication for surgery is ultrasonography dilated tube. Am I correct?
Yes. Yes, sir.
Okay. Is the live birth rate? Can I?
Yes.
Sure, Dr. Hassan.
Is the live birth rate in tubal factor in general lower as compared to other indications or not, without hydrosalpinx?
Without hydrosalpinx, it may affect only salpingitis. I think it has a deleterious effect on implantation, only salpingitis. Because some cases of unexplained recurrent failure may have pregnancy after tubal occlusion for only salpingitis, not hydrosalpinx.
Thank you.
So they have a deleterious effect, yes.
Thank you.
Thank you, sir.
We have some questions in the Q&A section. Timing of sclerotherapy before starting the cycle. How long do you wait?
Timing?
How long do you wait between sclerotherapy and starting the IVF cycle?
1.5 months or 6 weeks. 6 weeks and start.
Question from Dr. Ashraf Salima. Is there a chance for conservative management for hydrosalpinx?
There was antibiotics, but it's not useful because once hydrosalpinx accumulated, so there is destruction of the epithelium. So there is no absorption of the fluid inside the fallopian tubes. So I think no rule for antibiotics, only for management of hydrosalpinx. in my opinion.
Another question from Richard Mojni. Is there room for tuboplasty in patients who can't access ART? Tuboplasty?
Tuboplasty for hydrosalpinx, there is no rule for tuboplasty for hydrosalpinx. Higher rate of ectopic pregnancy, higher rate of recurrent pregnancy loss if pregnancy occurs from the other tube. So it's better to remove the diseased tube. Tuboplasty, I think, for peritubal adhesions, fembral stenosis, proximal tubal block, you can do tuboplasty using hysteroscopy, like tubal cannulation. But once hydrosalpinx, it's tubal damage or tubal destruction. So best is radical therapy, salpingectomy, or occlusion.
What can you do for small hydrosalpinx that appeared after stimulation that we didn't notice before stimulation?
Aspiration of oocytes, injection, Vitol, salpingectomy or tubal disconnection, and then frozen embryo transfer.
Okay. Does the stimulation itself affect the size of hydrosalpinx?
Yes, because fallopian tubes has receptors of estrogen and progesterone. So it may lead to some sort of edema or increase in the girth of the tube or the diameter of the tube. So if you have a mild hydrosalpinx, by stimulation, it may be changed to moderate hydrosalpinx, so it may be evident, like the previous question.
So definitely stimulation may affect the size of the hydrosalpinx, and maybe it was not noticed before stimulation and it can be noticed after stimulation. Okay. Another question, why don't you open the tube like large longitudinal incision instead of occluding it, which is something like salpingectomy, and leave it in place? Can we do something like this?
If there is adhesions and accumulation again, so you need to go for a previous surgery patient with inflammation and I think extensive adhesion around this area. So the second time it will be very difficult surgery. So the best is the first surgery to do the optimum, either disconnection with stoma or salpingectomy.
So can you do salpingectomy without occlusion? Is it beneficial for the patient?
I have said it's some sort of tubal damage. So there is no need to keep the tube in place. So no need to keep the communication between the tube and the uterine cavity.
So drainage drainage alone is not enough. You have to not enough. Okay. Thank you, Mohamed. That is all the questions.
Thank you, Sharif. Thank you, sir. We have I have voting.
Okay, please.
Till they vote, can I ask Mohamed a question, Dr. Sharif?
Dr. Hassan.
Unilateral hydrosalpinx is a question in the Q&A answers. What do you do for unilateral hydrosalpinx?
What do you do for?
Unilateral hydrosalpinx.
Tubal disconnection.
And you leave a chance for spontaneous pregnancy?
Yes.
Thank you.
You treat the disease and leave the patient to be pregnant spontaneously.
Yes.
If the other tube is healthy.
Sclerotherapy is risky, dangerous?
Very risky. Very risky. Because if the fembral end is opened or it leaks, it leads to escape of ethanol inside the peritoneal cavity. So you do sclerotherapy and put my hand on my heart. I did it twice in a very difficult cases. Hopefully one case of them was pregnant and it, delivered full term, but the other not.
So you don't recommend that everyone tries to do this, right?
No. In very difficult, very difficult cases. That's very dangerous. I have also a small opinion, Dr. Hassan.
Yes, please.
Hydrosalpinx decrease IVF percentage by about 50%. So if there is a risk of morbidity for the patient or increasing risk of any complication for the patient, so I prefer to give the patient lower pregnancy rate instead of giving her a morbidity.
Yes, of course. Yes, of course.
Because Hydrosalpinx only decrease the percentage.
Definitely.
Definitely.
The poll is ready?
Yes.
Fabulous.
Which procedure shouldn't be used for management of Hydrosalpinx? Hopefully, the result is 67% true. It's Essure device, which is the correct answer. Which is the wrong regarding Hydrosalpinx? There is a strong evidence that salpingectomy affect the oocyte yield, and the percentage about 63% was the true answer. Hydrosalpinx is best diagnosed by 2D ultrasound. Yes, true. 88% was the true answer. Histosalpingogram is useful for diagnosis, communicating Hydrosalpinx. The answer is true, and the 82% answered the right answer. And thank you.